Okay.
The next thing is it radiating to the back or not?
Yeah, sir. Any radiation to the back?
There's no radiation to the back, but she had some heaviness and left upper quadrant pain, which was persistent.
Okay, sir. Any aggravating or relieving factors, sir?
No, it was almost sort of a discomfort she had. She used to have, she only had early satiety and she was not able to take much food.
Okay, sir.
And she was having fatigue.
Okay, sir.
There was no history of fever.
No, sir. Favors.
And there was nothing
Yes,
else. There
sir.
was no vomiting, abdominal distension,
Okay, sir.
GI bleed, jaundice, or pale lady. Okay.
Any abdominal fullness or anything if she has
Yeah, she
noticed?
had the postprandial fullness and early satiety.
Okay, sir.
She has that left upper quadrant pain, fatigue, probably 1 to 1.5 kilos weight loss.
Okay. Yeah.
We can move on.
Yes. Past history.
Only thing you are not asked is somebody has got early satiety. You need to ask whether the patient has had an anorexia or not.
Okay. No issue.
She has got a left upper quadrant pain. She has got a weight loss. Pain is a left upper quadrant. Early satiety, thing, and any anorexia. No, very important, isn't it?
Yes.
Early satiety is commonly, where do you see early satiety?
Any mass?
Yeah, where do you see? Which conditions you see early satiety?
Which one?
Ascites, sir. Ascites. Then any gastric.
When you have ascites, okay, here is no abnormality. But if somebody comes without abdominal and say they've got early satiety, postprandial fullness.
What are your differentials?
What are your differentials in this?
Any gastric outlet obstruction, sir.
Any gastric malignancy. You don't need to have even a linitis plastica. Without obstruction will come to you with early satiety.
Yes.
Something is what not. But the most important thing is anorexia.
Anorexia, yes.
Even in a pancreatic malignancy, you can have anorexia and early satiety. You will not be able to eat much. Because here is a patient who has got a left upper quadrant pain and got early satiety and postprandial. She is 66 years old.
Yes, sir.
So what should run into your mind is it gastric malignancy? Is it pancreatic malignancy? All those things are.
Yes, sir.
All those things are important in your differential diagnosis.
Yes, sir. And also any organomegaly, because it's a dull aching type of pain, sir. Any cause for splenomegaly, any organ enlargement.
So the anatomical could be stomach, could be a
spleen, tail of
pancreas. Tail of pancreas, or if the patient has any altered bowel habits, it can be a splenic flexure growth.
Flexure growth, yes.
Okay, so these will run into you.
Yes.
Can it be a GIST tumor, large exhibiting mass?
The other thing is retroperitoneal tumors. Large GIST tumors can come with early satiety.
Okay.
Yes. How do they present with early satiety? Large gastrointestinal tumors.
Because of the obstructions, sir?
They don't have obstruct. What they do is GIST will always expand and it will compress on the surrounding structure. That's how they present. They don't come with, unless you have a leiomyoma inside a bowel loop, you think. But as we said, something is coming early satiety. Madam was talking more about retroperitoneal mesenchymal tumors which can produce. So all these things should run into your mind.
Yes, sir.
Okay? Yeah.
Yes. And if it is
so you have to ask for altered bowel habits. That's something which we do not include. You should ask. Anorexia is something, you think, weight loss. You ask for fever. Yes, and we already said there was no history of jaundice or this. Okay?
Any pain? Any pain, LBK?
Madam?
Any pain? Pain
is there. Left upper quadrant, dull aching, not radiating.
So, Manmohan, what else would you ask if the patient's got pain with the left upper quadrant? What else would you ask?
Any stuff?
So
Trauma,
one is
trauma in the past.
no, so one is dragging pain
Mm.
due to organ enlargement, or you can get some infarction, so you can get an
Infarction.
acute pain.
Yeah.
No, and then you can get a pain when if there is some infarction or laceration or something like that, they'll have a catch or deep inspiration.
Yeah.
And then you have this BOA sign, no? Radiation to the left shoulder,
Left
left
shoulders. Yeah, sir.
Yeah.
There is no history of radiation. Yeah.
So as Dr. Enrique has discussed, so the organs are splenic flexure,
Well,
you have splenomegaly, renal,
renal,
and tail of pancreas, and
pancreas.
maybe a retroperitoneal mass,
Yes.
exophytic gist. So these are
Yes.
your things that should cross your mind.
Okay.
And whether the patient has noticed any lump, I would definitely ask for that.
Yeah.
I would definitely say, has she felt any lump? Yeah.
Yes.
Okay.
No issue of lump.
No, she didn't feel any lump. She has not come with it. She did not feel any lump or anything, but she had some heaviness. Okay.
Yes. Okay.
Maybe add left subdiaphragmatic collection, large.
Okay. Large collection.
Large collection. Okay, sir. Okay. Coming to past history, patient is a non-hypertensive, hypothyroidism, and a bronchial asthmatic.
Next slide.
Next slide.
Anything else you wanted to ask, Jasmine?
There is no altered bowel habits,
except she was evaluated and was told that she had
anemia and low platelet count.
And a low platelet count.
Yeah.
Okay.
Any history of blood
So, what do you
transfusion?
think when somebody has come with a pain, fatigue, low platelet count, and anemia? What could be that organ?
Spleen, probably spleen, hypersplenism related, sir, because there is anemia and thrombocytopenia. With the pain, typical more of a dragging type in the left upper
Maybe
quadrant.
not radiating. So, probably we are dealing with a spleen there. And probably some disease which has produced a spleen and as well as possibly features of hypersplenism. Okay.
Yes, sir.
That is what the report was entirely from there. Okay, that is what they have said.
Okay, sir.
It was referred to us here.
Okay, sir. Any history of blood transfusion, sir?
No, no history of blood transfusion, no surgery in the past.
No surgery.
And she has not donated any blood also.
Okay,
good. That's a good question. Yes.
And no bleeding tendency.
No bleeding tendency. She didn't have any bleeding tendencies.
Okay, sir. Then coming to clinical examination, patient had mild pallor, no icterus, no lymphadenopathy, edema, or clubbing. Vitals were stable. On per abdomen examination, abdomen
No,
was
the
soft.
other thing you would look for here is any signs of chronic liver disease.
Chronic liver disease, sir. Any features of chronic liver
Any
disease?
features of chronic liver disease.
Okay.
Okay?
Yes, sir.
Like any parotid enlargement, debutus contraction, all those things you should finish it off.
Yes, sir. Any spider navy, parotid enlargement, debutrance contracture, ascites, and these things. There were no features, probably. Then vitals were stable. On per abdomen examination, the abdomen was soft. It was non-tender. There was mild hepatomegaly, moderate splenomegaly.
The span was about 13 centimeters.
Okay, sir. Margin, sir.
Margins are smooth.
Okay, sir. Surface, any nodularity or smooth?
Or nodularity.
Okay.
Consistency was probably a little firm. That's it. Anything?
Any tenderness, sir?
No tenderness, no bruising of the liver.
No. Okay. Then parectal examination, sir. Anything significant?
There's a moderate
splenomegaly.
There's moderate splenomegaly. She had a moderate splenomegaly, which was about 4 centimeters from the subcostal.
Okay, sir. Not too fluid. Okay, sir. Then
free fluid in the abdomen. Anything else you think we should look for?
Any dilated veins in the back?
There are no dilated veins in the anti-abdominal wall. Then where else you look for dilated veins?
In the back, sir, posteriorly.
In the posterior.
Posterior.
In the posteriorly, there are no dilated veins either in the back or in the front. Okay.
Okay, sir.
Anything else?
Sternal tenderness. See here,
Sternal tenderness.
yeah, the thing is here, you're getting only a hepatosplenomegaly, okay, with an anemia and thrombocytopenia.
Anemia and splenomegaly. There's no bony tenderness.
Okay.
In anything else. Okay.
So normally in the oral cavity, what all would you look for? Gingival hyperplasia. You should look for a large tongue. Sometimes amyloidosis can present the splenomegaly. So all these things. See, now the question is, probably we're not dealing directly with the liver, or maybe it's more of a splenohepatomegaly, you know? It's a splenohepatomegaly rather than a hepatosplenomegaly. Once it becomes a splenohepatomegaly, then your differentials almost get shortlisted to liver or non-liver.
Non-liver.
Once it becomes non-liver, then you have to be, you must know everything about hematology, no? So what are the things you look for? Pallor, jaundice, sternal tenderness, gingival hyperplasia, amyloidosis or large tongue, macroglossia. Right. These are the things that should strike. Large lymph nodes.
Okay.
All these are very important. And of course, very important signs of liver cell failure because she has got bicytopenia.
Yes,
have an information as bicytopenia like hypersplenism.
Okay.
And therefore, the veins become important. Ascites becomes important. I think this is. Varghese, anything else?
I think both liver disease with splenomegaly, hypertension, hypersplenism is one way of thinking. By primary hematologic disease, either a neoplasm or a non-neoplastic hematological disease like myelofibrosis, etc., can be there in the picture. So we have to think both liver as well as non-liver.
Non-liver.
Yeah.
Can we move on?
Yes. Then other systems.
You want to give a differential? Oh, no, 1 minute. I'll give you a differential. Yeah, Bhargav, just go back. Give your differentials now. Dr. Varghese has always given you.
One is myeloproliferative disorders because it's a splenohepatomegaly.
So you have to give, as Dr. Varghese says, that you have to give a differential diagnosis for liver. And differential diagnosis for a non-liver case of splenomegaly.
Okay. Early cirrhosis with portal hypertension.
In which portal hypertension
do you get last? What do you mean by early cirrhosis?
Because there is liver is palpable, sir. Because mild hepatomegaly was there.
You don't give a clinical diagnosis of early cirrhosis and all.
Early cirrhosis.
Cirrhosis, okay. Cirrhosis with portal hypertension.
In which liver disease will you get a massive spleen? That's your differential. When do you get a massive splenomegaly?
Where do you get a moderate splenomegaly and liver disease? In typical cirrhotics, spleen is not moderately enlarged. So when you see a moderately enlarged liver is moderately enlarged splenomegaly, in which you get a moderately enlarged splenomegaly.
Non-cirrhotic portal fibrosis.
Non-cirrhotic portal fibrosis, extrahepatic
portal vein obstruction. Portal vein or splenic vein obstruction.
Yeah, you can get a chronic Budd-Chiari where the liver may be splenomegaly.
Yeah.
If somebody is taking alcohol, you can sometimes get alcohol, but you don't get too much a bigger cirrhosis in this thing. So these are three things which, or you may have, if it is a non-liver, where all you can get a moderate splenomegaly in this patient. Somebody is 66-year-old, what will be your differential diagnosis?
One is hemolytic anemia, sir.
Classify, Manmohan, classifies hematological, classifies infection, inflammation, neoplastic, and myeloproliferative disorders. You must have a classification and give examples in some of these where you get a moderate splenomegaly.
So in hematological
infections such as chronic, infections such as chronic malaria, Kala Azar, then infectious mononucleosis, then neoplasms like lymphomas.
Lymphoma is a possibility.
Lymphomas.
In neoplasms, you can have lymphoma.
NPN.
Can leukemia produce?
leukemia,
Leukemias can produce.
leukemia,
Yes, CML can produce. Then
CML. Then myeloproliferative disorders, such as CML. Then polycythemia
Vera.
vera, polycythemia vera can produce. Then primary myelofibrosis, or essential thrombocytosis. There we have splenomegaly.
Myeloproliferative syndromes can produce.
Myeloproliferative syndromes.
Any storage disorders?
Storage disorders such as Gaucher's.
In this patient, at this age.
I think give a in pediatric age group in children.
Sorry, sir, it was not audible, sir.
In children, if you have got a moderate splenomegaly, you have to consider storage disease. Both of the different types of sphingomyelinosis.
Sphingomyelin.
Yeah.
Sphingomyelin deficiency, sir. Storage disorders. Niemann-Pick diseases. Glycogen storage disorders.
And then you have the infiltrative diseases like amyloidosis, sarcoidosis.
These things can be also. You need to have a differential diagnosis like this.
Yeah.
Okay,
hemolytic diseases. Do you get a large spleen?
No. No, sir, not
in sickle cell anemia, there will be autosplenectomy. Thalassemia, even in thalassemia trait, you don't get big spleens. Okay. Hereditary spherocytes also, you don't get big spleen. So you don't get a moderate spleen. Okay.
Cystosomiasis. Cystosomiasis presenting as non-cirrhotic portal fibrosis causes a massive splenomegaly.
Okay.
So, apart from malaria, calas are cystosomiasis.
That's one question. What is the most common cause of non-cirrhotic portal hypertension in the world?
Very commonly asked question.
Yeah.
Cystosomiasis.
Most common cause of cystosomiasis. Okay.
Sir,
I'm Srijaya. I want to keep one more possibility.
Yeah.
Hello. Good evening, sir. I'm Srijaya. Good evening, ma'am.
Yeah.
Ma'am, for infectious causes of splenomegaly, I also want to keep one cause, that is splenic hydatid. Large hydatid cyst in spleen can cause varying degrees of splenomegaly and some amount of hepatomegaly also, depending on the number of cysts in each organ.
Okay.
And rheumatology people always say Felty syndrome. It's a rare syndrome.
Felty syndrome.
Rheumatoid disease with splenomegaly. Very rare.
Rheumatoid arthritis, splenomegaly, and you have
neutropenia.
You have a nodular regenerative hyperplasia in the liver.
Yes.
Okay.
Yeah. Okay, move on. How will you investigate this patient? I think this patient has come with these reports. No, LDK. Next slide.
No, she came only with. This is the first investigation we did in March 2020.
Okay. So, what are the investigations you want now?
CBC, blood CBC. Then I want a peripheral smear, ma'am. Then ultrasound abdomen. Then coagulation profile.
Her hemoglobin
in CBC.
7. Yes, MCT was 74.
Microcytic, more of a microcytic
anemia. Leukocyte count was 3,000.
Leukocytosis.
Yes. So very mild thrombocytopenia.
Mild thrombocytopenia. Pancytopenia is there. This. Peripheral smear showed normocytic hypochromic anemia with leukopenia. With
even though the platelet counts of 1,40,000, the peripheral smear showed number of adequate platelet clumps here.
Okay, sir.
So she had a mild leukopenia and prothrombin INR was 1.23.
1.23, mildly elevated, sir.
Yeah, 1.23. This is okay. For us, up to 1.5 was normal in this situation. Yeah.
Okay, sir.
Next, what do you
want? Like ultrasound abdomen, sir. USG abdomen.
Liver function test?
Liver LFT, sir. Liver function.
So you have told that there is a possibility of a liver-related problem as well as a non-liver-related problem.
Yes, sir.
So if you don't ask for LFT, how do we know?
LFT, sir.
Can we have the next slide?
Okay. Bilirubin was 0.4, it's normal, sir. AST, ALT is normal. Alkaline phosphatase 68, GGT 13, and proteins is 6.6, 3.8, and 2.8.
So there is no AG reversal.
There is no AG reversal.
Normal.
Yes, sir.
Yeah.
So probably their functions are normal.
PTNR was normal.
PT normal, sir.
Except the platelet is 1,40,000, but there were adequate clumps in the peripheral smear. And she was having hemoglobin was mild anemia, and there was a leukopenia. And there's a normocytic normochromic anemia. Okay.
Yes, sir.
Next, what do you want? So if she has a liver disease, that means she has probably got a well compensated
liver disease, sir.
Okay.
Ultrasound abdomen, sir. USG abdomen.
Next slide.
Creatinine was normal, sir. Urine microscopy is normal. Sugars are normal. Viral serology.
Yeah, HBsAg, HCV, HIV was negative.
Negative.
TSH was normal.
Yes, sir. So viral liver causes.
It was hypothyroid. It was already on treatment. TSH was normal.
TSH is normal with adequate treatment.
Can we have the next slide? Yeah.
Ultrasound abdomen, sir.
You can tell whatever you want.
Describe the liver, first one. Yeah.
Liver looks enlarged, ma'am. Then dilated.
You can mention about the echo texture. No, that's all it's mentioned. Echo texture is normal. What was
normal echo texture, ma'am. With portal vein appears dilated, ma'am.
Yeah.
Dilated portal vein.
Echo texture of liver was normal.
Normal.
There was no surface nodularity.
Surface nodularity.
Yeah.
Then
no leso in the liver.
No, it's all in the liver, sir. Portal blood flow appears in the second image. It looks normal.
Portal vein was dilated.
Portal was dilated with normal flow. Then,
no, what else you look for in this apart from this Doppler of our portal vein?
Flow, sir. Direction of
flow in what? Portal vein and then?
Hepatic vein, sir.
Yeah, you need to look at the hepatic veins.
Yes, sir.
So the hepatic vein was normal. Flow in hepatic vein normal. Portal vein was dilated. Flow was normal.
Okay, sir.
There was no ascites. You don't see any ascites.
Yes, sir. No ascites. Then spleen. Normal echo texture, ma'am. Spleen appears.
Spleen was 16 centimeters.
Enlarged.
16 centimeters. Enlarged.
Enlarged spleen.
Normal echo texture.
What was the splenic vein diameter? Normal, splenic vein?
1 minute, I'll just tell you.
Must be normal. Looks normal.
Splenic vein looks pretty normal.
Normal. So
splenic vein was normal.
Normal.
And there were no. And what else you will look for in a splenomegaly apart from a splenic vein? You look for any
infarct, sir. Any
infarcts, then any what are other vascular structures you
do? Splenic vein thrombosis.
Then collaterals.
Collaterals. Any collaterals.
So when you have a look at the hilar collateral, it may correlate with presence of what? When you have splenic hilar collateral.
Chronic bed series, sir. Any collateral development.
Any splenic hilar collaterals will tell you the patient has got a portal hypertension.
Portal hypertension.
Correlate with presence of esophageal or fundal varix.
Fundal varix endoscopy.
So that's what you look for in a spleen. The spleen here, spleen is enlarged. As madam said, splenic vein, we didn't see any splenic collaterals. Echo texture is normal, and there are no any either hyper or hypoecho
lesions in the
spleen.
No? Okay, yes, sir.
Isn't it?
Yes, sir. There are no collaterals.
So there the liver is normal, portal vein is there, only the portal vein is
dilated.
and the spleen was grossly enlarged.
Okay, sir.
So why is it dilated? Can splenomegaly alone produce dilatation of portal vein?
What is forward flow portal hypertension? Forward flow. Increased flow can cause portal hypertension.
Increased flow can cause portal. That itself can cause. Increased splenomegaly, increased flow can cause.
Yeah, if you have a splenic artery aneurysm, you can have a huge flow and you can get it dilated and the liver will be normal.
Okay.
Yeah. So, because portal hypertension is flow into resistance. You can have increased flow and also cause a large spleen.
Increased flow also can cause a portal vein.
Okay, sir.
And we have the next slide.
Ultrasound abdomen. There is liver is normal in size, portal vein dilated, and spleen was enlarged.
There was no aside. This is what we got. There are no splenic collaterals in the
hilar.
Next, what do you want?
So she's got some fans. She's got a mild bicytomy. She's got anemia and this thing. She's got a spleen. She doesn't look to have any chronic liver disease.
Chronic liver disease.
Dilate.
Move on to the next slide.
Endoscopy to rule out varices, sir. Esophageal varices.
Varices, yes.
And there are no esophageal varices. Then there are no fundal varix. Then antrum looks normal, sir, except erosion. Normal. Sure.
So we did that so that there is no evidence of any. There are no varices there.
Varices. Varices are there.
Next, what do you want? Next slide. Should we move on?
Blood.
So probably now we are dealing with with normal liver functions, growth hormone time, normal ecotextual liver, only splenomegaly. There are no collaterals. So and hepatic veins were normal. So effectively we have come out of the liver, and her viral serology was negative, and so we are dealing only with the large spleen.
Large spleen with dilated portal.
We got a CT abdomen done.
Intrahepatic biliary radicals looks
what is
normal, sir.
Come on, yeah, is that biliary radical?
Dilated.
These are biliary radicals or what?
Don't say
contrast. What's it? Contrast CT, ma'am. This is.
What is the first picture? What is it showing?
Increase portal.
What are those vessels?
Hepatic veins, ma'am. Hepatic veins are.
Why did you say biliary radical?
Sorry. Hepatic veins look dilated, ma'am.
Dilated.
Yes, ma'am.
Where are they entering? Hepatic veins. Okay, just move on. You have to be fast.
So the liver looks pretty normal.
Normal.
Spleen is large.
Spleen is normal.
Spleen is enlarged.
Enlarged. No ascites.
So why didn't we do a CT at all? She's got left upper quadrant pain. She's got fatigability.
Thrombus, splenic vein.
There's no thrombus. Hepatic veins are normal here. AVC was normal. There was
lymph nodes. To evaluation of the lymph nodes.
Or any lymph nodes. Do you see any lymph nodes here?
No.
You get a splenomegaly. There are no lymph nodes.
No lymph nodes.
Or any. So in fact, we did CT abdomen and CT thorax, and they were.
Okay, so normal.
So how should you proceed with this patient now?
Bone marrow evaluation.
Maybe right, if you mind.
Good.
Dr. Varghese, anything else?
No, I think that's what we done. Let's not look like a primary liver disease now.
Yeah,
and
now
we have to
we are dealing with a splenomegaly. Okay.
Yeah.
and there are no nodes. There are no
No
nodes.
lymph nodes.
He suggested actually a bone marrow for her, but by that
Okay, sir.
this is already it was already April 20th or so.
Okay, sir.
And she refused to come out of the house because the COVID was surging. Okay, COVID was surging. So can we have the next
Okay.
slide? So she did not come for follow. We told them we need to get a person. See, this is what we look. So liver measures
Okay,
normal
sir.
in size.
Yes.
Caudate.
Regular.
Only thing they said is caudate lobe is
It's prominent.
prominent. Surface is regular.
Okay,
Spleen measures 16 centimeters, mild to moderate. Evidence of colon splitting has a OG junction.
sir. Collaterals.
No,
Okay.
no wall
Look,
thickening. No significant paraffin. So we are just left with a splenomegaly,
Nervagil.
no lymphadenopathy,
Pathy.
liver disease,
Yes, sir.
and bicytopenia.
Bicytopenia.
Okay.
Bicytopenia.
So she didn't come to us for nearly 8 months. Can I have the next slide? In fact, we suggested we should do a bone marrow.
Bone marrow.
So, what are your differential diagnoses now? So, here is a lady who's got a pain, has got
Yes,
fatigue,
sir.
recent onset, bicycle splenomegaly. So, probably we will keep to those things. It could be either a neoplastic asthma,
Neoplastic.
it could be a chronic infection, and it can also be myeloproliferative
Myeloproliferative disorders.
disorders.
Yes, sir.
Now, from the available peripheral
Yeah.
one will be able to rule out chronic myeloid leukemia, certain things
Yes.
like that. Because that was one of our
There's no
differential.
CML,
Doesn't look like any sort of acute leukemia, chronic leukemia.
or chronic leukemia.
Yeah.
No polycythemia.
No
No polycythemia vera. There is no hemolyte. There's no hereditary spherocytosis. There was no spherocytosis. And we didn't really think of a hemolytic disease of either because near
LFT was
Coimbatore,
normal.
increase you get a lot of thalassemia and thalassemia, sickle thal traits. So
Okay.
we looked at it, that was not there. But she just, when we suggested a little more workup, she went off from here and she was at home. Okay. Next slide.
So the differentials here would be, your infections, malaria, kalas, or schistosomiasis would be one. Then you have the other infiltrative disorders like amyloidosis. They may not
Ma'am, can
Yeah.
we schistosomiasis will some examiner get cut off? Because
No.
schistosomiasis,
No, that will be the last. That will be the last differential. That's right at the end. Last.
malaria, kalasa, okay.
Yeah, and then you have the other differentials where the difference there is not the same storage disorders like type 4 glycogen storage. That's one thing you'll have to keep in mind. Then what else will be there? Then your amyloidosis. I made a diagnosis once of amyloidosis as infiltrative disorders, lymphomas. But no nodes are there. Okay,
No lymph nodes.
No nodes.
Then
There are no
myelofibrosis.
nodes in the mediastinum. Amyloidosis.
Myelofibrosis.
No braces.
Myelofibrosis
No
will also
braces.
come as a disease. So these will be my some of the
So
differentials.
lymphoma,
With anemia, with leukopenia, thrombocytopenia, and with moderate spleen, and the patient may be living longer without much problem also.
Yeah.
Yes.
Myelofibrosis could behave like this, no? Large spleen.
It's large spleen. Splenomegaly is there.
Can you move on? Next slide.
again. So she was
Lost for
also follow from March to December, and she was readmitted on 28th December with a vague abdominal left side. Now she was not able to eat, and she had a history of weight loss of
4 kg. Okay.
Okay.
Yes, sir.
The physical exam.
Next slide.
Next slide. General examination is normal, but for mild paler, it's similar to before. Per abdomen, no dilated veins or anti-abdominal wall or back. Gross splenomegaly.
Yeah. This time, look at the word. No, that this time the spleen has become really bigger.
Really big. It was
8
moderate
months we
splenomegaly.
found that the spleen was earlier moderate. Gross splenomegaly. There was a mild, and hepatomegaly was 2 centimeters below the costal margin. There are not much changes in the consistency of the liver.
Yeah, okay.
There's no free fluid.
Good.
No, nothing else. But right now, she has lost another 4 to 5 kilos.
4 kgs.
She was not able to eat, but the spleen is much bigger. It was higher. It's almost reaching up to the about nearly quite a big spleen. We could find the difference because I had seen 8 months back.
Okay, sir.
Okay.
Yes.
What else you want?
Next.
When do you think such a thing would happen? That a spleen enlarges over a period of time. You know? Now your DD gets. When can you get? Say malaria colors around be fixed. No?
Less.
You won't get.
Yeah, ma'am. It won't
So
be enlarged.
infiltrated disorders, yes.
Yes.
Amyloidosis, anything that's infiltrated.
Amyloidosis, active sarcoid.
Active sarcoidosis. Yes, yes.
A lymphoma can.
Lymphomas.
Then
my primary myelofibrosis, sir.
Myelofibrosis, yes.
You should consider.
I think these would be the shortlisting once you have a large amount.
So now over 8 months, she has lost another 5 kilos of weight.
Yes.
She was looking, she was almost looking very sick.
Okay.
And she has not had, any other systemic symptom. There was no fever or anything.
No fever.
Next slide.
Next slide.
Go ahead. Then we have the next slide.
Okay. Hemoglobin is similar, so 9.3. It was 9.7 that time. Total count also 3,100. With platelet persisting at 1.5 lakh. ESR is elevated. With peripheral smear showing normocytic normochromic to microcytic hypochromic anemia with leukopenia and mild thrombocytopenia this time. With derangement in the coagulation profile, sir. INR is elevated, 2.22.
So there's no liver disease. So we thought there's no liver disease.
Yes, sir.
But that time you see it was PTNR 1.23.
2.23.
Now it is 2.22. So what's happening? So there was no liver disease. Absolutely, there's no liver disease. There's no portal hypertension. There's no portal hypertension. No, there are no collaterals. There are no varices.
Yes, sir.
Spleen has become bigger. The liver looks normal, but now the PTINR is
prolonged.
So how do you sort out this issue? Why do you think the PTNR is prolonged?
Worsening of the liver function test, sir, or probably because of
okay, you are the worsening of the liver function. The LFT. Wait. So the next slide you have put something.
LFT is normal.
Wait. Well, I'll tell you the LFT during December admission. 1 minute, doctor. The LFT during the LFT was completely normal.
Okay, sir.
The LFT was completely normal. Platelets are 1,50,000. ESR has gone up, and so there was no progression of the liver disease. So there was no liver disease.
No liver disease.
And the PTINR is now prolonged. So how do you sort out this issue? So PTINR can get prolonged either due to a covalent deficiency or
what? Vitamin, where is drugs related, sir? If on any.
She went off home, doctor. She went off home. She was only in folic acid.
Malabsorption syndrome, sir.
No, she has had no diarrhea, nothing. She has just come back only with enlarged spleen, fatigability, and she's got lost another 5 kilos of weight. Now, see, how do you say what else can happen? So how do you, when somebody has got this, how do you sort out whether it is coagulation defect or something else? So you do what is called a half patient, half control. You do a half patient, half control. You correct it with
corrected APTT ratio.
Can I have the next slide? Next slide, please. See here,
LFT is normal.
LFT is absolutely normal. Protein albumin thing. Serum uric acid. LDH has gone up from probably 180 to 335. Reactant was 0.5. It's absolutely, LFT is absolutely normal. Alkaline was normal. Gamma GT is normal. And even there is no AG reversal. So we are not dealing with the liver disease. So we need to give a half patient, half control. Can we go to the next slide?
LPK, can you just explain that?
Yeah, I'll come to that. So we did another ultrasound.
Okay.
So the liver is enlarged inside. So that situation was there, that LFT was normal. And we also thought that she have any liver disease which has worsened now. Enlarged liver. Liver is now 19.7 centimeters. Total weight is 15 millimeter. And spleen, which was 16 centimeter, had gone up to 21.3 centimeter. and spleen is now displacing the left kidney. So this is our situation. We didn't still see any nodes in her. Okay.
Okay.
Next slide. So compared to previous USG, which was done in March 20, ultrasound abdomen showed increase in spleen 5 centimeter. PTINR is prolonged. So how do we proceed further? So what we did is we did a half patient, half control. If it is getting corrected by your plasma, it is a coagulation defect. If it is not getting corrected, it is a circulating inhibitor. Circulation.
How do they do it? Can you just explain in detail?
I think they take the patient's plasma and take a normal patient's plasma, and then they mix it up, and they wait for about 20 minutes to see if the PTINR is getting corrected in the patient. Okay. So we send it to hematopathology, and this is what we do. So you do think circulating inhibitor. Can you go to the next slide?
Can we go to the next slide?
Okay. After test and
so after the prothrombin time is, so when we send a thing, what our hematopathology do is they do this, and they also do a coagulation assay. Completely they look at the coagulation assay. So what did happen is the prothrombin time is prolonged, but not corrected with the normal plasma. Okay. There was normal APTT, thrombin time, and fibrinogen levels. So that means there is no efficiency of
intrinsic factors,
including fibrinolytic system. But your prothrombin time is prolonged and it was not corrected. So that means there is a circulating inhibitor.
Circulating inhibitor.
What they found was there was a mild decrease in the
factor 7.
Factor 7. So that means now there is a decrease in factor 7. So that means inhibitor which has decreased the factor 7. So we looked at the electrophoresis just to see if there is multiple myeloma or something. Because it was not corrected, we looked at the Coombs test that was negative. And we looked at ANA profile and ANA. AD coming with the spleen as she got ANA, that was negative. What is the other you can look up? Can we go to the next slide? So the that we should look for antibodies. So we have this anti-card positive. So this is possibly the circulating inhibitor, which has increased prothrombin time. As there was also inhibiting the factor 7 deficiency. So when somebody has got a splenomegaly and circulating inhibitor, what is the most common possibility you will find? It was a you don't get such big spleens, no? But here is a patient whose spleen is going up, fatigability. The suggestion was that most commonly it would either be a myeloproliferative disorders or a lymphoproliferative disorder. Because everything was going on, so even in a myeloproliferative, you don't get everything was going on. So the first thing they said was possibly it could be a lymphoproliferative disorder. So we went with what do you do next?
LBK, when you get that long prothrombin time, what should you ask to the hematologist?
Half patient, half control test.
Okay.
When you ask for us in the hematopathology, they do this half patient, see if it is getting corrected. If it gets corrected, it's a coagulation defect. If it is not getting corrected, then they look for an assay. Factor 7 assay sometimes can get all the inhibitor may be within some assay. And they ask you to look for an antibodies. They'll also check for the fibrinolytic system, like they also look for thrombin time, APTT, and fibrinogen.
Just out of ignorance, can TEG help in this patient? TEG.
We didn't do a TEG because only platelets were normal, and when you had this, only the PT was prolonged in the absence of liver disease. Platelets were quite okay. So we just did this because we want to look at the circulating inhibitor. So this is what we did. And we were strongly suspecting, and one of the things is lymphoproliferative diseases, myelofibrosis disease can always cause this problem. So the suggestion from our head of hematopathology is to exclude a lymphoproliferative disease. That's what they told us. So what do you do next?
Bone marrow, sir. Bone marrow examination.
So we did a bone marrow.
Next slide.
Next slide, please.
Bone marrow section.
So we did a bone marrow biopsy,
which showed linear fragment of the bony trabeculae enclosing 8 to 9 hypercellular marrow spaces. So adequate bone marrow was there. Then erythropoiesis appears increased and shows normoblastic maturation. There is myelopoiesis shows immature precursors predominantly over mature cells with prominent eosinophils precursors. There is megakaryopoiesis appears normal. Also seen are aggregates of lymphoid cells arranged in both of paratrabecular pattern as well as in an interstitial pattern. Was there?
Next slide.
Next slide. So it was a infiltration by a polyclonal population of lymphoid cells, T and B cells, in a background of normal trilineage hematopoiesis. So polyclonal infiltration of the lymphoid cells were there in the bone marrow.
So bone marrow has shown that there is no myeloproliferative disorder. There is no myeloproliferative. And it has shown only infiltration of lymphoid cells, polyclonal. It is not monoclonal.
Monoclonal.
Okay?
Okay, sir.
They are not so. So we have only a splenomegaly. So there is no CML. There is no lymphoproliferative diseases. We have because it was all going up. It was also becoming bigger. We have ruled out tropical splenomegaly. So we are left only, and CT abdomen has not shown any nodes. It shows only a thing. Bone marrow has shown only a polyclonal this thing. So in the presence of splenomegaly, which is going up bigger. Number 2, patient has been losing weight. Then a patient with having a circulating antibodies factor 7 deficiency. But bone marrow refined biopsy is not showing any clue. But one of the strongest possibility of circulating melatonin is a lymphoproliferative disorder. So how do you prove it is a how do you think we should look for a lymphoma in this patient?
Spleen biopsy, sir.
That's a little dangerous. I'm very scared to do a spleen biopsy. Such a big spleen, you do a biopsy, she bleeds, so there's no way you can do anything. What else can you do? What do you do, supposing you do, to get the diagnosis? What else can you do? IHC from where? Somebody called Dr. Joe said IFC. Unless you have a tissue, you can't do an IHC. You can't do an IHC unless you have a tissue. I'm scared of doing a splenic biopsy. But there's a large spleen with a lot of vascularity. She may bleed, no?
Yes.
And she happens to be one of our very, very administrative officers from PSG. Okay. What else can you do?
Liver biopsy, sir.
Hey, there's nothing in the liver. Liver biopsy, yes. Liver biopsy is something which I considered, but there was nothing in the liver. But the spleen has grown bigger. So what else can you do? Can you remove the spleen? What do you call that term? What do you call that term? Huh? Have you heard a term called diagnostic splenectomy? You've not heard a term called we can remove the spleen and send it for diagnosis. So we consider doing diagnostic splenectomy, and you are right. I also asked for a liver biopsy in this patient. Okay, sir. We thought diagnostic splenectomy may give us a clue. Okay. So we agreed, patient agreed. So before splenectomy, what are the precautions you will take?
Vaccinations.
What vaccines?
Meningococcal, pneumococcal, capsulated organism vaccination, sir. Then
Influenza vaccine.
Influenza vaccine, sir. Influenza vaccine.
Will you give hepatitis B vaccine?
And hepatitis B.
And hepatitis B. And hepatitis B vaccine, sir.
Hepatitis B vaccine, why in this patient? We generally don't give it for all patients, but why in this patient? If it turns out to be lymphoma, then you need to have, no?
HBS is related.
She was anti-HBC negative, so that's what we vaccinated her. Okay. So commonly you do vaccination.
Vaccination.
After how many days of vaccination you will take up for spinning?
No.
2 weeks. 2 weeks after vaccination, we do a splenectomy. So we went ahead with a laparoscopic diagnostic splenectomy. Okay. Can we have the next slide? Immediately before that, they wanted a PET CT. They said intensely hypermetabolic. I was not very keen, but the surgeons want PET CT. The oncologists wanted PET CT. Intensely hypermetabolic splenomegaly. Few intensely hypermetabolic gastrosplenic peripancreal, measuring 2 centimeters with a resting. So there was issue whether we can go and reach this lymph nodes
and take a lymph node.
But it was not possible by. Other thing is, could we reach by US? But we were not very sure whether we could reach it by US. So this was interesting. This has now appeared. This is the first time the nodes have appeared. We'll decide we'll go ahead with a diagnostic splenectomy, and if possible, to take this node at the same time do a liver biopsy, get a core liver biopsy.
Okay.
When you do laparoscopy, you get a core biopsy. Okay.
Yes.
Can we have the next slide?
She was planned for diagnostic splenectomy as
so now the problem here is she's planned for a diagnostic splenectomy on the PET seed bone marrow. So now she has got a prolonged PTINR and she has got a circulating inhibitor, APLA antibody.
Bodies.
So the implications here are, let me tell you, the implications are: one, because she has got a prolonged PTINR and circulating inhibitor, she can bleed massively due to surgery. Okay?
Yes, sir.
And because she is an AMPLA antibody positive, because that is the factor 7, she can bleed massively during surgery. At the same time, once you remove the spleen, because there's an AMPLA antibody, she can also post-venous thrombosis.
Thrombosis can be there.
So how do you treat this inhibitor? We thought they said it could be APLA or it could be any other inhibitor. So she was given 3 doses of methylprednisolone before surgery, 500 milligrams of methylprednisolone, and for the surgery, during the day of surgery, we gave preoperative and perioperative, preoperative FFP to bring it down. And then for a splenectomy. Okay?
Okay, sir.
After we did a splenectomy, you need to put her on. What happens once you do a splenectomy to the platelet count?
It increases.
They increase. Honestly, it can go up to 10 lakhs, 12 lakhs. So she can develop thrombocytosis. Since she also had an APLA antibody positive, she was started on. How do you prevent complication?
Anticoagulant, sir.
Yeah. Tell me, man. You are telling me.
Anticoagulant, sir. Warfarin plus aspirin.
Let's say. Okay.
Flexin was there, sir.
Okay. So she underwent diagnosis intra-lymph node biopsy. Liver biopsy was done on 29/1/21. Can we have the next? So this is the implication of the circulating inhibitor. So you have to cut this 1 minute. Just hold back the biopsy. Bhargav, go back to the previous slide. So here the implication is that you need to really bring down the antibody levels, I think, and correct the coagulation before surgery. So she was given 500 milligrams of methylprednisolone with telling the patient relative that she can go in for a massive infection.
Bleeding and infection.
So because she was given methylprednisolone, and we are going to remove the spleen. So we need an infective complication and
Bleeding complication.
a bleeding complication and thrombotic
Complication.
complication. So all this have to be taken.
Okay.
After that, she was put on antibiotics.
Antibiotics.
Included a gram-negative, vancomycin, and antifungal.
Okay.
Okay, this was what was.
Okay, sir.
Okay. Then on the 5th day, she developed high spiking fever. And she had diarrhea. 5th day or 7th day, high spiking fever, 102, 103. Platelets were 12 lakhs. And the increased frequency of stools. And she had a mild pain in the left upper quadrant. Counts were actually the count went up to 17,000 or 18,000. And she had a diarrhea which was about 10 to 14 times a day, semi-solid stools. It was on meropenem, vancomycin, and fluticasone. So, how do you look for fever in a post-splenectomy patient?
Infection, sir.
So, you will send the cultures.
Cultures, blood cultures, and stool routine, stool cultures. Sir.
Stool routine and
stool cultures, stool for ovocyst.
Stool for ovocyst, and here the patient got a
Clostridium difficile, sir. C difficile.
C diff is getting. So, stool culture was negative. C diff was sent. Meanwhile, we got an ultrasound done which showed a collection in the splenic fossa. So, what do you do?
Probably that is got infected, sir, because of which.
You don't know. No? So, we got so you probably is better to do a CT and see the. Then, when there's a collection, we put in a
drain, sir, drain.
So, we put in drain, but only the blood clot came out.
Okay, sir.
Culture was negative, but the fever was spiking. And the C diff is positive. Both toxin A and toxin B are positive.
Okay.
So possibly she had an acute
C difficile infection, sir. Second,
post
difficile infection, post splenectomy.
By having mantle. Okay.
Yes.
Okay.
Okay, sir.
So then we changed over to oral vancomycin.
Vancomycin.
How do you treat C difficile?
Oral vancomycin, sir, will be given for 10 days.
Please read about C difficile infection.
Okay, sir.
So what is it? What is mild? What is moderate? What is severe? All those things. How do you treat these patients? So the fever?
Paracetamol.
Yeah, no, the fever set after treating this. So in a post-splenectomy, you need to really look for, you should be very careful when they get infection. You need to do cultures, you need to do a see if there's any collections. And at the same time, they got a diarrhea, get a C difficile done on these patients.
Okay.
Okay, then slowly the fever settled down after going to oral vancomycin.
Okay.
And oral metrogyl. Okay.
Okay.
Can we have the next slide?
Next slide. Spleen biopsy. It shows splenic tissue with expansion of white pulp by micronodules consisting of small to medium-sized lymphoid cells. The larger nodules and areas of coalesce are present. The medium-sized lymphoid cells have conspicuous cytoplasm and are seen proliferating in the marginal zone. Large cells with vesicular nuclei, some with nuclei are interspersed. Sinusoidal involvement is evident. Areas of hemorrhage and fibrosis are also observed.
Next slide. Can we have the next?
Next
slide. Yeah.
IHC marker study, which showed the medium-sized cells show cytoplasmic and membranous positivity for CD20. These cells are negative for CD10. Then cyclin D1, CD23, CD5 and CD3 stain highlights numerous reactive T lymphocytes dispersed among B neoplastic cells. Ki67 proliferative index is low, around 10%, and CD23 highlights dendritic meshwork in the center of the follicles.
Can we have the next slide, please?
So lymph node biopsy. The section shows lymph node exhibiting a phased architecture with replacement of follicles by medium-sized and small lymphoid cells. Few large cells are noted.
Next.
The liver biopsy. It showed section shows linear fragment of the liver tissue with preserved architecture. Hepatocytes were unremarkable. One of the portal tracks shows an aggregate of small lymphoid cells surrounding interlobular bile ducts. The rest of the tracks are normal. IHC marker study, it showed medium and large cells show strong membranous and cytoplasmic staining. Many reactive CD3 cells, CD3 and CD5 positive reactive T lymphocytes are seen. Cyclin D1 is negative. Next slide. Impression was splenic marginal zone lymphoma with florid reactive T cell component. Splenectomy specimen was showing it. Then peripancreatic lymph nodes with involvement by lymphomas. Then true cut liver biopsy showing focal portal lymphoid cell infiltration.
So this is what they sold is a splenic marginal zone lymphoma. Thing. So that's why the true cut liver biopsy also showed some focal portal lymphoid cell infiltrate, but it's very suggestive. But pancreatic lymph node, this time there were nodes which was involvement by the lymphomas. The marginal cell lymphoma. And later again, the oncologists were not happy that we did only on one side of bone marrow. So then we went ahead and did on both sides the bone marrow, because oncology always says you should do on both sides, so that has a prognostication. Can we have the next slide?
Bilateral bone marrow biopsy from right iliac crust. The section show linear fragment of the bony trabeculae enclosing 13 to 15 intact hypercellular marrow spaces. These spaces show erythroid series with normoblastic maturation. Myeloid precursors show sequential maturation. Increase in eosinophilic precursors are observed. Megakaryocytes are mildly increased. Also, seen are aggregates of lymphoid cells both in the paratrabecular and interstitial location and scattered plasma cells. Whereas left iliac crest section show linear fragments of bony trabeculae enclosing 6 to 8 intact hypercellular marrow spaces. These species show features as described above. So bilaterally, it was the same similar findings. With
next slide.
Next slide. So IHC done on both the right and left side. With short lymphoid aggregates observed in
summarize it. I think
just summarize it. Go to the next slide. Next one.
Next one.
So the above model is the bone marrow in. Sorry.
Just go back. Just go back. This
bone
one.
Marrow right, lymphoma. The first time we did, there was only some monogenic lymph nodes, but of course we didn't do IHC at that point of time. But this time suggested infiltration lymphoma. So in 8 months, this is basically a marginal cell lymphoma. Lymphoma with now showing a bone marrow. And only other question it came up during our discussion was, could we have had a repeat bone marrow on bilateral both sides before we
stop sharing
from splenectomy before we go in for splenectomy again bone marrow to find. But we thought without the initial monogenic, it was only monogenic cells, so we went into the diagnostic splenectomy. So this is basically a splenic marginal cell lymphoma, involvement of the bone marrow, the lymph nodes. So she has now been admitted, and she was initially given steroids, so that hydroxyurea, so that the platelets comes down, and her total count also had come down. and platelets have come down from 12 lakhs to now 4,78,000. And after a 3 week of steroids, she now been started on rituximab. They thought rituximab is what this thing. That is why anticipating rituximab, we have given the fast track of hepatitis B vaccination. We did on 0, 7, and 28. These days of this one we did.
Okay.
So this is a case, but I thought I will share more of the things because I didn't want to stop only with some discussion and say lymphoma and go.
Okay.
But I think this is a case which the learning objectives are one. What is our differential diagnosis of liver? As very beautifully put up by Madam and Dr. Verghese, that it has to be liver and non-liver. You consider both the differential diagnosis.
Okay.
And when you have a prothrombin time elevated in the clear-cut liver disease, how do you analyze that?
Okay.
There is a circulating inhibitor.
Inhibitors.
What factor is deficient? And if you don't have notes, when you go in for a splenectomy or any these patients, and APLA antibody is positive. And APLA is positive in a situation where there is a large spleen, in a patient who has rapidly lost weight. Lymphoma is a major probability. And when you do a splenectomy, what are the precautions you take pre-splenectomy? And during, because of the circulating inhibitor and factors in this thing, you had a risk of both a bleed as well as a thrombotic state. This one. And this thrombotic state was controlled by methylprednisolone to bring down the inhibitor levels as well as fresh frozen plasma to increase the factor 7. And immediately post-operatively, after 12 hours, we started flexane on this.
Okay.
Post-operatively, in a patient who's got a post-spectomy status, you need to look if there is a fever, you got to be very proactive in looking for infections. And do an imaging to rule out any collections after post-operatively. And if the patient has diarrhea, look for a CD tox.
CD. Yeah, sir.
Okay, so
I think I was just wondering, the hematopathologist should be really good to do these inhibitors. I was just wondering how you did, you did that PT and control.
Yeah, and so the learning objectives are one, as usual, differential diagnosis. How do we work up? How do we exclude liver? How do we think? And bone marrow. IHC is very, very important in these patients.
Okay.
And then how do we manage CD toxin?
Okay.
In this patient, in that initial bone marrow biopsy,
it was only polyclonal. It was only polyclonal B and T cells. That's what it is. I think Dr. Prasanna took nearly 1 week before she gave us the report. And she said no, and then she only suggested you go for a diagnostic treatment. The only issue came up when we had a tumor board meeting is the oncologist said whether you could have just gone back again, doing both sides bone marrow and a PET scan. But maybe that's one thing we could have done because they said it would be very, very risky to do a splenectomy in a patient with a lymphoma. And I think it went on well after controlling both the circulating inhibitor and adequately giving her FFP and then paralyzing her.
Wonderful.
Now the liver also has shown a monoclonal missing some infiltration, but IHC was not very big. But both lymph node and bone marrow have shown infiltration. Maybe the disease has progressed in 9 months of what has happened.
But these case LVK. Wonderful.
It's a very good, very well worked case, very interesting case. I would say it's extremely interesting and many learning points. So many learning points. Starting from simple clinical splenomegaly to all problems of APLA, coagulation inhibitors, and all those things. Very, very interesting.
I personally feel that PGs should know a little bit more of hematology. Because once you get the splenomegaly, it will all be hematological discussion. So you have to read beyond liver.
As most of the examiners are all-timers, the general medicine is fairly strong. And general medicine is fairly strong, so they go into hematology as well.
Into greater depth,
yeah. It will always go to hematology.
Very interesting, LVK. Thank you so much. She's around. No?
Srijaya.
Srijaya, your comments? The D is Srijaya, I think.
She's a tremendous.
She's around. Yeah. Thank you very much, LVK. Wonderful.
Thank you so much, ma'am. Thank you very much. So it is a very rare case.
More than that, I think it's a
Very
workshop,
managed.
no? I think
Very
LVK,
worked out and well managed. And
LVK, I think it's that multidisciplinary approach that you have in your hospital, no? Where you're able to discuss everything in one go. I think that is
It's just like your NGM CPC.
CPC, yeah, exactly.
It's just such standards.
High standard, very high standard. Wonderful. Thank you.
This is Varghese, this is what I was telling about the clinical grand round. You know, this is how I picked this up when I was in France. This is how it happens, a clinical grand round. So when you wanted me, we'll do it in your thing. You gave me some dates.
Yeah, we look forward to it. We look forward to it.
Yeah, wonderful. Thank you, Manmohan. You did but you're very hesitant, okay? You have to put up on your, you're gathering the answers from the examiner.
It may not be a very garden variety of exam. We see by the time the exam, what happens is it just, beyond that investigations and the time is over. But this is something in your practice also, you should know how you approach.
This is more important, It's not necessarily for exam point of view. I enjoyed that PT, PT INR alone being prolonged.
Yeah, that's what I think. But that's only PT which is half PT INR is prolonged, but the implication of that is
that's very important.
It is so much important than we were really scared when she went for surgery. You know? So everybody were on dose, whether the FFP was given, methylprednisolone given.
Most of these LVK, most of these patients will have an inhibitor.
Yeah, that's what Madam Prasanna Madam, she is our hematopathologist. She said they'll have inhibitor. And she was the one who said, just rule out lymphoma in this because we didn't have anything else except for the spleen. We were wondering tropical splenomegaly, but she said no. When a circulating inhibitor is there, the most common thing will be a lymphoma on these patients. They have it. So she gave a detailed report of this and she said that there is a factor 7 deficiency.
Wonderful. And I like the word diagnostic splenectomy. I never heard of it also.
Yeah, this is a diagnostic splenectomy. I think I think Varghese is there, no? Diagnostic splenectomy.
I have not heard of it.
Yeah, I am also hearing it for the first time.
First time.
Anyway, you escaped very well with that splenectomy.
You escaped very well, exactly. Yeah. Thank you, LVK.
Thank you.
Get back home. Yeah, thank you, PT. I hope you enjoyed this.
Are in the hospital?
Yeah.
I'm still in the hospital. Yeah, I just finished my OP at 9 o'clock and then started.
He is GK incarnation, So he'll go only at 12 o'clock. Bye. Good night.
Okay.